Ladies and gentlemen, the image in the New England Journal last week is shown here. It's a 35-year-old man who presents actually to a psychiatry department because of paranoid delusions. They thought his hair looked funny, and you're asked to make a diagnosis. What's given here is androgenic alopecia, centrifugal cicatricial alopecia, syphilis, trichotillomania, and hypothyroidism. Well, this is not an androgenic pattern of hair loss, and it's not a cicatricial pattern of hair loss. Those are localized phenomena, and this seems more generalized. People that tear their hair out with their hands have trichotillomania, and that's generally also localized to some specific area. And we studied hypothyroidism several weeks ago, and that's a generalized hair loss. So we're left with syphilis, which can certainly result in mental derangements and paranoid delusions. And that's the correct answer. This is called a moth-eaten appearance of hair loss, as if a bunch of moths had just randomly at certain areas of his scalp ingested his hair. So this is a moth-eaten appearance, and that's what that is called clinically. And a single injection of benzathine penicillin G generally results in cure, still today. So this is androgenic alopecia. The temples are involved here, or the center, or the back of the head. That was certainly not the case in our patient. This is cicatricial alopecia. This is actually a petrolatum burn that can be accrued in patients in cosmetic studios trying to get a particular style of hairdo. This is hypothyroidism. This was the patient that we saw several weeks ago who also has loosening of the nail beds, onycholysis that's called. And when this 44-year-old lady was treated with thyroid hormone, her hair loss certainly recovered, as shown here. This is a patient with trichotillomania, and you can see that the hair loss here is localized to specific areas where he grabbed his hair and pulled it out with his fingers. And this is another example of a moth-eaten appearance where the hair loss is generalized and localized areas, as if moths had ingested his hair. The big topic in the New England Journal is aspirin. And aspirin is actually the trade name for acetosalicylic acid. This was developed in Germany at the end of the 19th century and was taken over by the Bayer company that still market this material today. It is a widespread medication that's used for all sorts of things, primarily pain, headache, whatever have you. Years after the material was introduced, primarily men who shave noticed that it increased the propensity to bleed, and that was finally traced to a blockade of platelet function. Here is the synthesis of aspirin. When I was a college student, one of our assignments in the laboratory was to make aspirin from sodium salicylate and an acid material, and the way that it was made at the end of the 19th century. Now, aspirin inhibits cyclooxygenases and therefore interferes with prostaglandin production. This phenomenon was discovered by John Vane in the 1970s with very simple techniques, and for this work he received the Nobel Prize. Aspirin irreversibly binds to cyclooxygenases, and cells that have a nucleus can make more cyclooxygenases to counteract the effect of aspirin, but platelets have no nucleus, so that when aspirin is bound to COX-1 and platelets, that platelet is lame for the rest of its lifetime. It takes about 7 days to make a new platelet, and therefore aspirin is very effective in inhibiting platelet function. There are various tests, separate tests that can be performed to observe the effects of aspirin, as is the case with other platelet inhibitors, as I show on this slide here. Now, the guidelines indicate that aspirin should certainly be given to patients that have had a myocardial infarction or stroke in the framework of secondary prevention. Now, in the latter part of the 20th century, aspirin was tested in terms of primary prevention in the Physician's Health Study. I was a subject in that study, and also in the Nurses' Health Study, and there was a modestly favorable effect of aspirin on decreasing cardiovascular risk. Other studies have also shown that aspirin may impair the proliferation of colonic polyps and decrease the risk of colon cancer. That's also said. So in 2015, the guideline gurus in the United States suggested that aspirin should be given to persons with a distinct cardiovascular risk as a primary preventative if the patients were aged between 50 to 70 years of age. The studies that we're going to look at tested the primary preventative effects of aspirin in patients that are 70 years or older, because these patients don't live forever, and if they don't die of cancer, they die of cardiovascular disease, and cardiovascular disease is the most common cause of death. So in this first study that was performed in the United States and Australia, older persons were recruited and randomized to aspirin or placebo, and in this first report, the primary endpoint was a composite of death, dementia, or persistent physical disability. And the secondary endpoint was hemorrhage. So here are the patients. There are almost 10,000 patients in each group. That's a lot. And half the patients are my age or even older. And various ethnic groups were represented. And I'm afraid all these folks are a little too fat. And some of them, not very many, still smoke, and diabetes occurred, and hypertension, and all of the sorts of things that you would expect in an older population. Here are the significant differences. And the only thing that cropped up was major hemorrhage, and that was more common in the aspirin group compared to the placebo group, as you might have imagined. All the other primary and secondary endpoints were not statistically significant. And what we see here in this fairly robust population of elderly individuals, there weren't very many endpoints anyway, but there was certainly no difference between aspirin and placebo. So it doesn't appear that aspirin protected from dementia, death, and disability. And recall here that almost 20,000 patients were randomized here to take either aspirin or placebo. And if you can't show it in 20,000 patients, it may not be that relevant. So here, persistent physical disability, no difference. Dementia, no difference. All-cause mortality. It actually looks a little higher in the aspirin group, and we'll come back to that and look at why all-cause mortality was higher. So in this population of individuals, aspirin did not prolong survival, and it did not prevent dementia, but it did cause more bleeding. Now, this same study was analyzed in another way, and in this second analysis, the primary endpoint was cardiovascular death. And this was also a collective endpoint of cardiovascular disease in these same patients. Again, the hemorrhage part we've already seen, but what we can look at in terms of cardiovascular events, no difference in the hazard ratios in the people getting aspirin compared to placebo. So aspirin was not in a position to decrease cardiovascular death in these patients, and that's shown here. Look, a number of events that occurred here, even in 20,000 patients at this age group, the number of events was small. That may be related to the fact that these people were having their blood pressure treated and having their diabetes treated and other factors that weren't generally appreciated in the latter half of the 20th century. We can't address that for certain. But here again is major hemorrhage, and that was more common in the aspirin group compared to the placebo group. And that's shown here. So it doesn't look like aspirin decreases dementia or cardiovascular death in people that are older than 75 years of age or older than 70 years of age, which would question the use of aspirin in this older population in terms of primary prevention. Now, I'd shown this one picture where all-cause mortality looked more increased in the aspirin group compared to placebo. And that was examined in more detail in this same population of patients. So there's 20,000 people, almost 10,000 in the aspirin group, 10,000 in the placebo group. And what we see here, to our chagrin, is that death related to cancer was actually higher in the aspirin group compared to the placebo group. So that could explain why the mortality actually in the aspirin group was higher than placebo. And we can ask ourselves why. There was certainly no protection from colorectal cancer in this study, or from pancreatic cancer or breast or brain cancer. That was responsible for an overall risk of cancer hazard ratio of 1.3 in the aspirin group compared to placebo. And you can see a breakdown, body mass index, dyslipidemia, frailty, whatever have you. Those are scattered all over the place, and there's no significant differences that can help us here. So it looks like the cumulative incidence curves for death from any cause and cancer-related deaths were not different in the first 3 years of the trial, but moving over time, there was an increased risk of cancer, and nobody knows why. And these results should be interpreted with caution. The next aspirin study looked at, well, if it doesn't help these old people that are pretty healthy, maybe it helps old people that have diabetes. And so in this study, it was primarily performed in Great Britain. 15,000 older persons with diabetes were randomized to aspirin or placebo. The number that were greater than 70 was not as great as in the earlier study. But here again, the primary efficacy endpoint was cardiovascular event, and hemorrhage was carefully monitored. And again, not very many events, probably because these patients were also having their blood pressure controlled and their lipid values lowered and their diabetes sensibly treated. So it looks like the aspirin group does a little better than the placebo group, and indeed their hazard ratio was decreased, and that was even statistically significant. But their bleeding risk was increased, definitely increased. So here in terms of major bleeding, the placebo group does better, but in terms of cardiovascular events, the aspirin group does better. So how do we interpret this? I guess you can tell your older diabetic patient in terms of primary prevention, you can take your choice. You might have a gastrointestinal bleed, or you might have a cerebral hemorrhage, or you could perhaps have a slight decreased risk of stroke, or a decreased risk of having a myocardial infarction. So it looks like the benefit and the risk sort of canceled each other out in this study, and that was shown in all elements of the trial, a breakdown of the patients in the trial with the highest risk or the medium risk or lowest risk, and we see that the patterns in each of these groups were the same. So In terms of the cancer business, again, there was no reduction in gastrointestinal cancer in this large population of patients observed for a fairly long time, but they're going to have to be observed even longer to make a firm commitment on that particular issue. So in terms of old people that have blood pressure controlled and lipid values and diabetes pretty well under control, in terms of primary prevention, I don't think we can draw any conclusions that they're helped by the administration of aspirin, whereas their hemorrhage risk might be increased. The next issue is fatty acids. And this is a tedious issue. You'll recall that fatty acids are a chain of carbons connected to another of a certain length. There's a carboxyl group at one end. That's the potential hydrogen donor. That's why they're acids. Then there may be some double bonds in some of these. There may be not. And the structures may be cis, which indicates that where there is a double bond, the configuration is such that the subsequent bonds are not in parallel, but instead have this configuration. Or they may be in trans, which indicates that the element is twisted 180 degrees so that the subsequent carbon bonds are indeed in parallel across from the double bond as shown here. Now these fatty acids can be either saturated, which means that they have no double bonds, or unsaturated. They can be in either cis or trans, and what's shown here is alpha-linoleic acid, which is a cis fatty acid that has a double bond at the omega terminus 3 carbons away, and it's called an N3 fatty acid or omega-3 fatty acid. Here's an example of oleic acid that does not have this configuration at the 3 position. This fatty acid is saturated here, and this is an example of a trans fatty acid. Now, when I was in medical school, we were taught to tell the patients that they should eat margarine instead of eating butter because butter was toxic because it was high in cholesterol and margarine would be better for them. Well, subsequently, we've discovered that margarine features trans fatty acids, and these have even been declared against the law in New York, to my knowledge, and now the nutrition gurus tell us that these fatty acids are bad, so margarine has moved from being good to bad. What's supposed to be particularly good is if we eat cis fatty acids that are N3, that have this double bond at the 3 position if you're counting from the omega terminus. And so alpha-linoleic acid is a good fatty acid, whereas oleic acid is less good, and trans fatty acids are bad. That's that in a nutshell. So what was done in this next study is a recruitment of patients with diabetes mellitus that were supplemented in good fatty acids, that is to say N3 fatty acid supplements, in the hope that the primary endpoint, myocardial infarction, stroke, trans-ischemic event, cardiovascular death, etc., would be improved. Whereas the secondary outcome in the study was the first serious vascular event or the requirement of needing arterial revascularization. So this study tests what the nutrition experts tell us should be a no-brainer, that N3 fatty acids are good for you and should make us invincible in terms of cardiovascular health. So here's what came out. 10 years of follow-up, not very many events, no significant difference. And you can look at the hazard ratios here, fatty acids better or placebo better, nothing happened. And we can look at a breakdown here in terms of other potential events that might have happened, and these things are not statistically significant. So we can conclude that N3 fatty acids are probably not bad for you, but there's no evidence in this diabetic population that they're particularly better for you than other fatty acids in terms of dietary supplementation. Now, the review in the New England Journal is on addiction. And I didn't really understand this. The title of the paper is Brain Change in Addiction as Learning, not Disease. I even translated the title into German, and I still didn't understand it. But what the author says, that the current model of addiction is that it is a brain disease, that through taking drugs or alcohol or whatever else is addicting, that there are actually changes within the central nervous system that are hardwired that result in the addiction phenotype, if you will. The craving and all those things go along with it. And this makes addiction a disease rather than a learning disorder that could perhaps be helped by behavior modification. If it's a hardwired disease, then we would have to develop tablets to deal with it. And this disease theory has been advanced because it's very acceptable to the patients. That means that they've got a disease and it's somebody else's fault. It's not really their fault and they can't help it. So this argument focuses on biological factors. It's reduced the stigma of addiction and is therefore more acceptable for the patients and the doctors treating these patients. The author of this review argues that this idea is wrong. And so here's a table of the brain disease model and the stigmas and the way that people interpret this. Some of this is conclusions drawn from functional MRI studies, which I would think would be rather difficult to refute, but that's the matter of debate. And the author proposes the learning model, which allows for empowerment. I don't know exactly how to translate this into German because I'm not exactly sure I know what it means in English. But this would indicate that we could teach these people to perhaps take control over their lives, to deal with their addiction, rather than just to rest on the conclusion that this is a hardwired problem. So here again, in table 3, we see a comparison of the disease model, the learning model that the author favors, and the evidence for applying this model, and how we can perhaps deal with these patients in a different way rather than writing them off as being a hardwired brain disease, and perhaps someday we'll develop some tablet that could help them. So the author disputes the idea that addiction results in pathological brain changes. So if you're into this particular topic, you can read this review and look at his recommendations and draw your own conclusions. Now, last week we looked at these remarkable fingernails in this patient that is being treated for Hodgkin's lymphoma with a standard regimen, and every treatment results in a line like this. And these are Mies lines that develop as a result of injury to nail matrix, same as seen in patients that are subject to arsenic poisoning or have episodes of the nephrotic syndrome or problems of this nature. So these are Mies lines as opposed to Merkes lines, which are related to abnormal nail bed vasculature. Then in the New England Journal is this remarkable video clip that you can look at, and in systole and diastole, this large mass flips between the left atrium and the left ventricle. This patient had a third heart sound, but it was not a gallop rhythm from heart failure. We call this a tumor plop, and you can see this wonderful echocardiographic example here. So this tumor was excised, and then this patient was no longer short of breath. Now, the patient in the New England Journal this week, this is a therapeutic dilemma. This is a 36-year-old woman who's in her 36th week of pregnancy. She develops severe lower back pain that becomes intractable, goes to the doctor, gets an ultrasound examination of the abdomen, has hepatic lesions, and on the basis of these hepatic lesions, an MRI scan is done, which shows numerous, most likely metastases, liver metastases. Then a CT was done, which you don't like to do in pregnant women because the radiation exposure here is substantial, but we see here packets of lymph nodes, and there's also some bowel thickness and things of this nature. And she's in her 36th week of pregnancy, and the problem is, what do we do? So what was done here is a diagnosis was established with a liver biopsy. Then some laboratory work was done, and as you'll see here, carcinoma embryonal antigen was markedly elevated. CA19, these are tumor markers, those were markedly elevated, indicating that she has a malignant disease, probably some malignant tumor of the gastrointestinal tract with liver metastases. That indeed was the case. And since this is her first successful pregnancy, she's faced with the dilemma of a premature birth and perhaps risk to the fetus, waiting, delay in chemotherapy and removal of this tumor. And this is a therapeutic dilemma because there are two patients involved here, the mother and the child, not just one. So a large sigmoid malignancy was identified here. The patient opted not to deliver prematurely. So this pregnancy was carried for several more weeks. Then it turns out that it was a breech presentation and a cesarean section had to be done. The baby was fine. And then the question is, how should this poor woman be treated? And while the investigators were arguing about which chemotherapeutic modality to employ, this poor woman died of her tumor, and that was the discussion in this particular case report. Now, the question of the week in the New England Journal has to do with neonatology, and it's an example of a methadone-exposed infant. Mother is an addict, received methadone during pregnancy, and the infant shows signs of irritability after delivery, which is indicative of withdrawal syndrome in this infant. And the question is what to do here. And the examples are treat with diazepam, don't like it. Initiate dextrose infusion. I think measuring blood sugar would be a better idea. A dark, quiet environment, or place a nasogastric tube for continuous enteral nutrition, or initiate treatment with low-dose morphine. Well, if you don't have experience with working with this clinical problem, how would you know? And I picked low-dose morphine, which was wrong. The correct answer is a more conservative first try, moving the child to a dark, quiet environment to see if the problem might be alleviated and go away on its own. Then we move to the Lancet, and the first topic of the Lancet is gout, gouty uropathy, gouty arthropathy. This is a major common clinical problem, and it's a classic clinical problem. And here's an example of a patient with podagra, and you can see the destructive lesions when x-rays are done. And if we aspirate these joints, we can, if we look at the fluid under polarized light, we can see these monosodium urate crystals. And the problem here, the biochemical problem, is in the metabolism of purines to guanine and hypoxanthine and finally xanthine. We metabolize xanthine to uric acid or urate. We and the Dalmatian coach hound are the only mammals that are not able to metabolize uric acid to allantoin, which is much more soluble and can be easily excreted. In our case, it's a problem that we have the gene for hepatic uricase, but it's just not turned on. So we're stuck with making uric acid, and we're therefore prone to get gout. Now, we can block the metabolism of xanthine to urate with a medication that's been around for 50 years, allopurinol. And allopurinol is the medication of choice for treating gout, but the treatment for gout is generally not very effective. And the question is why? In the UK, gout management is suboptimum, with only 40% of patients receiving adequate urate lowering therapy. So it looks like the doctors aren't very good at this. So what these investigators did is they randomized patients with gouty arthropathy, with gout, to either be treated by a GP with usual care or to be treated by specially trained nurses that were told exactly how to treat gout. And these nurses do exactly what they're told, whereas doctors seldom do exactly what they're told, irrespective of how many guidelines are published. So that was done, and this was the background of the study, so that this is a parallel arm, non-blinded, randomized trial looking at 56 general practices where patients were either randomized to the general practitioner or randomized to a nurse that knew what to do. And if we look at this table, we can see here, here's nurse-led care. These are the nurses and these are the doctors. And what you can see here is suddenly things are very significant. P is less than 0.0001. The nurses are beating the doctors in these taking urate therapy, the serum urate concentrations, 2 or more flares, 4 or more flares. The nurses beat the doctors in every category. And here's why. The doctors measured uric acid at the beginning, and then they measured it a year later, and the uric acid wasn't any lower with their treatment approach. And then they measured it at 2 years, and it still wasn't any lower. That's because they didn't increase the dose of allopurinol. Now, the doctor's favorite dose is 300 milligrams of allopurinol a day. And in 8 of 10 patients, that's not enough. And up to 800 milligrams of allopurinol might be necessary. So the nurses had a different approach. They were told to measure uric acid every time the patients showed up. And if the urate levels weren't below this dotted line here, they increased the dose of allopurinol. And they did much better than the doctors. So here you can see the lower urate concentrations, the number of flares were less, the portions of patients with tophi was markedly improved. So nurses are better than doctors at treating chronic illnesses. And if the investigators had picked hypertension management or type 2 diabetes, I think they would have probably gotten the same result. Interesting study. Next study is carpal tunnel syndrome. A large proportion of older adults have this. And the problem here is with this retinaculum, the volar aspect of the wrist, results in an entrapment of the median nerve. And that results because of degenerative inflammatory changes here. And with entrapment of the median nerve, this results in pain and weakness and non-functioning hands. So if you're a concert pianist, you don't want this. Now, this condition can be treated operatively, but before that is done, it's generally treated with nighttime splinting, or an alternative is to inject corticosteroids that can also result in relief. And that's what was done in this study. These patients with relatively mild carpal tunnel syndrome were randomized to nighttime splinting or single injections of methylprednisolone. And the methylprednisolone group did better. But then methylprednisolone is more expensive than a splint and has other disadvantages. But the injection group at 6 weeks were definitely better. At 6 months, there wasn't that much of a difference. But in terms of measuring quality of life and these various scales that you can measure discomfort, the steroid-injected group did better. So it's a function of how much is the healthcare system willing to spend on this problem. And if the healthcare system is stingy, then the splinting is probably the better alternative. But if the healthcare system is generous, then the patients get a higher quality of life with the steroid injections. So that was the data in this study. Now the next study is also important. It involves chlamydia trachomatis. And this is a major cause of blindness in the third world. But in the rest of us, since we almost all have this somehow, it causes urethritis, cervicitis, prostatitis, epididymitis. This is the most common sexually transmitted disease that there is. And the question is, should screening be performed for this, because it's oftentimes asymptomatic? And the treatment is effective, the problem can be handled with doxycycline, and the problem can be eliminated. So that's what was done here. In this large study in Australia, this is a cluster trial where not patients are randomized, entire practices are randomized to either screening or no screening, and the endpoints were pelvic inflammatory disease, and the hypothesis that was tested was, is screening worthwhile? Does it make a significant difference, or is it all a waste of time? So the evidence before this study, according to the investigators, is they didn't know if it were a good idea or not. So the trial was performed. And here's the intervention group compared to the control group that were also screened according to recommendations, but the intervention group had a specific focus on screening. And if the women were found to be positive, the partners are brought in and they're questioned about urethritis, etc. And if they're positive, then they're also treated. So this shows the intervention group got a lot more screening than the control group, as you can see here. In this particular graph, these are women tested. These are patients tested per year. And here are the male partners of whether or not they were tested. And there was a significant difference. The tested women had slightly less pelvic inflammatory disease. This is kind of borderline, and this was the only significant difference that I was able to identify with this more focused screening approach to this problem than what was generally done. But it might be that we could decrease the incidence of pelvic inflammatory disease, sterility, and the things that go along with it with a more careful screening for chlamydia. And probably it would be a good idea to specially train nurses to do this that would probably do a better job than doctors. Now, the review in the Lancet has to do with the Alma Ata Declaration from 1978. You won't remember this. At the time, Alma Ata was in the Kazakhstan Socialist Soviet Republic. Subsequently, that has, of course, been changed. Kazakhstan is now relatively independent from Russia. But the Alma Ata Declaration, first of all, called for a fundamental health care for all people on the planet as being their individual right. Here are the delegates. And the other thing that was done at this declaration is that goals were set for the health of the world in 2035. And in this follow-up evaluation, this large panel of people, that some of which participated in this conference in 1978, looked to see how things are doing. And the good news is that the global trends of mortality for some things, such as HIV mortality, HIV couldn't be treated in 1978, is actually pretty much on schedule. But the decline of maternal mortality and tuberculosis is not as good as it should be, and neonatal mortality is also not up to snuff, and healthcare being a generalized phenomenon has also not yet occurred, not even in the United States, one of the richest countries in the world. Here we can look at a map in terms of yearly income in various countries, and the green countries are well off. Saudi Arabia here. They may not have freedom of the press, but they've got money. And these other countries where people make less money and where they're lagging behind in meeting these Alma Ata goals. So the red lines is where we are. The blue line is where we were projected to be. And the decrease in childhood mortality under 5 years has really been pretty good. We're almost at that point. And the decrease in AIDS mortality is also acceptable. Maternal mortality is not yet acceptable. Tuberculosis is still a major problem, but the total incidence of tuberculosis is down. And here you can Actually, I think this news is generally good, and you can look at mortality rates in 2015 compared to 2000, and the trend in general, I think, is not so bad. And here you can look at the progress of individual countries. China's doing pretty good. Some countries are not doing as well as they should in certain areas. The Chinese are very good in general, but they now have a higher incidence of cardiovascular disease, so that's why these red dots are over on this right-hand side of the slide. And it's a function of how much money is spent on these issues in these various countries, as you can imagine, but we're hopeful that additional innovation will occur to make the outlook better. Now, one topic that the Lancet never touches is the massive increase in population that happens because of improvements in healthcare, which I think cannot be denied. Now, since I graduated from medical school, the world's population has doubled. And the question is why, and whether or not that's good or bad, I guess depends upon your frame of mind, and if anything can be done about it is also not clear. But this is a science paper from 2011, and it shows, and now things are more dramatic than they were in 2011, but we've certainly decreased the death rate, primarily by reducing childhood mortality and this sort of thing. So we've increased the number of young people in the market that aren't dying of malaria and diarrhea and these kinds of things, whereas the population growth rate has not decreased. And the projection is that we hope that it will decrease in time, but nobody knows for certain. And some of you may be familiar with a book written by Thomas Malthus in 1798 called An Essay on the Principle of Population. He drew attention to population growth, which is geometric, a geometric progression. He concluded that it would be similar to the growth rate of bacteria, that have a phenomenal increase in growth and then eventually an increase in death rate and a collapse. And he projected this for humans also. His projections have not been correct, but it may be that they would be correct at some later time point. And in this science paper, they talk about infant mortality rate and total fertility rate and how these things coincide. So this is a map of countries by fertility rate in 2018, and the fertility rate has dropped in the blue countries, those are the rich ones, with some exceptions, and in the poor countries, fertility rates are at very high levels, as is also shown on this map. 7.6 successful pregnancies per woman would be the red group here, and 1.3, that's still an increase in population growth in these countries that are in the green part of the map as shown here. And then what will this do to the demographics? Initially, there's going to be as population increases, there's an increase in young people, but if they don't die of disease, they end up being old, and this results in projections that were made in this paper for Indonesia and Nigeria, and we can see here the massive increase in young people, but eventually even young people get old. That increases the number of old people in the population, and presumably the younger people under age 65, they need jobs, or they're not happy, or they're poor, and old people may need care, and these are major social issues discussed in this paper, which I think are worthwhile keeping in mind. Finally, in the Lancet was this lady, 76-year-old lady, comes in for a routine orthopedic operation, has an echocardiogram, and this is a little bit difficult to see here, but her left atrium is compromised. And her left atrium is being compressed by osteophytic spurs emanating from her thoracic vertebra, as shown here. There's also a video clip of this. This lady probably would have problems at maximum exercise, but she's basically asymptomatic, and the clinicians decided not to do anything about this. But this is compression of the left atrium through bone spurs emanating from the thoracic vertebra. And with that, it's over for this week in English. Thank you that you joined me.